Now we'll be discussing about a special joint that is present in the upper limb that is called as the elbow joint. What's special in it? And what is the type of joint? And what are the movements that are taking place? See, usually people will feel difficulty in the level of joints. What are the movements? How to remember all the relations, etc. My simple suggestion is if you just go for only 5 to 6 diagrams, the entire elbow joint will be completed. Trust me. Just only 5 to 6 diagrams, and that makes your elbow joint very, very clear. And what are the points to remember at the every level of the diagram will be made easier. Okay, let's go with that of elbow joint. So first, any joint if you are discussing, then you will be describing about what is the type of joint, right? So let's start with that of elbow joint. So any type, first when we are starting any joint, the first thing we have to discover what is the type of the joint. So elbow joint type is a hinge joint of synovial variety. See, synovial joints are many subtypes are there. In that, hinge joint is that subtype. So hinge joint of synovial variety is a type of joint. So in this hinge joint, what do you mean by hinge joint? Means it's just like I say hinge, so that there is only one plane of movements. See, in the, for example, in the elbow joint, we have only one plane of movement, that is flexion, extension, flexion, extension. There is only one type of movements are there, and it just acts like a hinge, and hence the name is given as hinge joint. Okay, so that is the first thing that we will be discussing, that is called as what is the type of joint. It's a hinge joint of synovial variety. And the next thing we will discuss is what are the articular surfaces. Second thing is articular surfaces. So let's see the diagram. The first diagram we will be going here is, we are showing in the left side there is an image. In that image, I am showing the elbow joint from the front view or the anterior view. In this, the lower end of the humerus consists of a structure called as C, and the C represents for capitulum and T represents for trochlea. So the articular surfaces at the lower end of the humerus is capitulum and trochlea. So C is for capitulum and T is for trochlea. So those are the articular surfaces at the level of lower end of the humerus. Next, in the lower part, that's the upper end articular surface. In the lower end, what are the articular surfaces? This structure is called as the radius, or for radius, and this is called as the ulna, and within the ulna, this is called as trochlear notch. So trochlear notch. Okay, so R is for radius and Tn represents trochlear notch. So these are the articular surfaces. What are the importance of these articular surfaces? What is the speciality of these articular surfaces? So let's discuss first of trochlea. Trochlea is a rounded structure in the lower end of humerus, which is smooth in the inferior side and also on the anterior side. So first is capitulum, rounded structure, smooth on inferior and also anterior. Inferior and also on anterior sides. Sir, why only on the inferior and the anterior sides? It has to be smooth. Because see, capitulum actually articulating with that of R, that is called as a radius, particularly to say radial head. So whenever the radius is in the anatomical position, it will be inferior surface articulation. But during the flexion, the radial head will come to the anterior surface. So if inferior and anterior surface are smooth, then the movement of radius over the capitulum also will be smooth. That's called as the smooth movements of the joint. So that is why the reason only the inferior and the anterior surfaces are smooth in case of capitulum, which is rounded structure. That is what the reality features of this of capitulum. Next, coming to that of trochlea. So trochlea is the one which is having a pulley shaped structure. We had said as capitulum has a rounded structure, but trochlea is a pulley shaped structure. So that's the difference between the shapes. And what is the importance of this is, in this we have, this side is called as the medial flange and this is called as the lateral flange of trochlear notch. So the medial flange is much larger when compared to that of lateral flange. Medial flange is larger when compared to that of lateral flange. And this is the same reason why we have the carrying angle. And what is that carrying angle? We'll discuss the further sections. That's about the upper articular surfaces. Now coming to the lower articular surfaces, we have two bones. On the lateral side is the radius and the medial side is that of ulna. And within that radius, the upper part is called as head and the head is rounded. Rounded head for the rounded capitulum. And within that rounded head, the upper part will get depressed. See here, I had just made a depression here. This entire is rounded. In the upper end, I had made a depression. That means the upper end has a depression for the enlargement of capitulum, which is above. Upper end depressed. Why it is depressed? Because it has larger capitulum, right? Next is trochlear notch. And this trochlear notch is formed by two processes. One is the olecranon process, the other is coronoid process. So what is olecranon? What is coronoid? See, the upper projection, ulna is actually having a notch-like structure in this manner. The upper projection is called as the olecranon process and the lower projection is called as coronoid process. These two processes together forms a notch-like structure. And into that notch, this medial flange and the lateral flange will get fit into. That means simply to say the trochlear notch will get fit into the trochlear notch, right? So trochlear notch formed by coronoid process and also olecranon process. So in this diagram, what we had learned, articular surfaces. What are the upper, I'm just giving the summary of these diagram. What are the upper articular surfaces? Capitulum, trochlea. What are the lower articular surfaces? Head of the radius and also the trochlear notch. Capitulum, rounded, smooth in the inferior and the anterior. Trochlea, which is pulley shaped, where medial flange is larger when compared to lateral flange. The same exactly opposite in case of for the fitment of this capitulum, the head of the radius has to be rounded and the upper end has to be depressed. And whereas the trochlear notch is formed by two processes, olecranon and that of another process called as coronoid process. Okay, that's what regarding the first diagram represents the articular surfaces. So if the articular surface is there, then these articular surfaces has to be connected by certain fibrous capsule. So let's discuss about the ligaments now. Because ligaments comes under the fibrous capsule is a part of the ligaments. So the next topic we will be discussing is ligaments. The third one, ligaments. In the ligaments, the first thing we will be discussing is fibrous capsule. So what is the function of this fibrous capsule? It holds the bone, the articular surfaces intact. So that's why there is a fibrous capsule. So what is the importance of this fibrous capsule and what are the attachments of this fibrous capsule? Let's see in these images. First I am showing the lower end of the humerus where the articular surface is extending. Our articular capsule or fibrous capsule is getting attached. It extends. Let's imagine this is the medial end. This is the lateral end. In the anterior view and in the posterior view of the humerus, this is the medial and this is the lateral. So in the medial side we have medial epicondyle and in the lateral side we have lateral epicondyle and the same in the posterior view also, right? Why I am saying this? Because the fibrous capsule extends from the lateral epicondyle towards the medial epicondyle, making a convexity above on the anterior side and also the convexity above on the posterior side. That's what the attachment of fibrous capsule over the upper part, that is upper part of the elbow joint, that is the lower end of the humerus to say. Okay, once again I am saying fibrous capsule attachment is from medial epicondyle to lateral epicondyle like a convexity from above, or we can say concavity from below. So during this convexity, both on anterior and posterior side, on the anterior side it is enclosing a small depression on lateral side and also a small depression on the medial side. I will show this. Can you see this small depression here? This is one depression and this is another depression. The lateral side depression is present above the above that of the capitulum, and that fossa is called as radial fossa. This is called as radial fossa. Why the name radial fossa? Because during the flexion, the head of the radius will come and lodge into that fossa above the coronoid, above the capitulum. So the fossa name is given as radial fossa. In the same way, in case of medial side, there is another depression, and that depression is called as coronoid fossa. Why coronoid fossa? Because the lower projection of this trochlear notch is called as coronoid process. And during the flexion, the coronoid process will be coming and then fit into a fossa which is present above the level of trochlea. As coronoid process is getting fixed into that, so the fossa name is given as coronoid fossa. Right? Very simple. There is no need to by heart anything or thing. Just use the common sense. During the flexion, on the lateral side, radius is coming, and on the medial side, coronoid process coming. And hence the fossa names as radial fossa and coronoid fossa. Okay, then what about the opposite movement, that is called as extension? During the extension, the olecranon process, the upper part is called as olecranon process, will get fit into the posterior side of the humerus, and there is another depression here on the posterior view, and this depression is called as olecranon fossa. All these fossa are non-articular. Please remember, we had already discussed articular surfaces, what they are. But they are present inside the joint of the fibrous capsule, but they are not articular, or simply to say non-articular fossa. Radial fossa, coronoid fossa, and also the olecranon fossa. They are non-articular fossa, which is filled with extra fat, which is present in the fossa. That's what regarding that of this image, and the fibrous capsule extension in the upper part of elbow joint. What about the lower part of elbow joint? In this, the lateral bone is called as the radius, and the medial bone is called as ulna. And can you see here, there is a ligament that is called as annular ligament, which is present around the radius, around the head of the radius. There is a ligament is there. Now, where is the attachment of these fibrous capsule in case of lower is? It will attach to the entire level of annular ligament, but not to the radius. Please remember that it attaches only to annular ligament, but not to the head of the radius. That's the first thing. And it also continues the attachment to the anterior part of coronoid process, medial part of the coronoid process. And the same will be continuing as the medial part of olecranon process and the anterior part of olecranon process, and then continues with the head of with the annular ligament on the lateral side. So lower where the fibrous capsule attachment is annular ligament, not attached to the radius. Please remember, not attached to the radius. Next, over the ulna, it attaches to anterior and also the medial sides of coronoid process, and also the medial and superior part of olecranon process. So this is the olecranon process, and the lower one, this is the coronoid process. So anterior and the medial sides of coronoid process, and medial and superior or the anterior parts of these olecranon process will be the attachments. So this is what regarding the attachments of fibrous capsule in case of elbow joint. So I'm just summarizing the things. So the third part we are discussing is ligaments, and within the ligaments, the first thing is fibrous capsule, which makes the articular surfaces to hold in position. Now these articular surfaces are kept in position by this fibrous capsule. What are the attachments in the upper side? That it extends from medial to lateral epicondyle with convexity above, enclosing two fossa anteriorly and one fossa posteriorly. The two fossa which is present anteriorly are the radial fossa and also the coronoid fossa, and the posterior side is called as olecranon fossa. Whereas in the lower part, it encloses around the radius by attaching to the annular ligament, but not attached to the radius. Please, I'm repeating the statement. Whereas in case of the ulna, it attaches to the anterior and medial part of the coronoid process, and also the medial and anterior or superior surface of olecranon process. This is how the attachments of fibrous capsule. This is one of the ligaments. Apart from these fibrous capsule, there are certain stability ligaments that is called as medial ligament or medial collateral ligament and lateral collateral ligaments. So let's see those ligaments also. So the second one we are discussing is in the ligaments, medial collateral ligament. In the medial collateral ligament, as we had said, the fibrous capsule is up to the level of lateral epicondyle and the medial epicondyle. The medial collateral ligament starts from medial epicondyle. From there, the anterior fibers will be going towards the coronoid process. The posterior fibers will be going to the olecranon process. And the middle fibers are there at the junction of those two. So three subdivisions are there in the medial collateral ligament. One is the anterior fibers. Second one is the middle fibers. Then backside is the posterior fibers. Right. So in the anterior fibers, where they are attaching to the top coronoid process. In the posterior fibers, they are attached to olecranon process. The middle fibers will attach to the junction of the coronoid and olecranon process. Junction of coronoid and olecranon process. Okay, so three subdivisions are there. And where they are starting from is from the medial epicondyle. The medial epicondyle they are starting. So that is what the starting point and the ending points and these three subdivisions in the medial side. And on the lateral side also there has to be a certain ligament that's called as lateral collateral ligament. The third ligament is lateral collateral ligament. And this will be extending from the lateral epicondyle and they will be extending towards the annular ligament but not to the radius again. They are extending only to the top annular ligament. So from lateral epicondyle is the starting point and there they will be extending to the top annular ligament which is present around that of the radius. This is what the extension. There is no such subdivisions like that of medial collateral ligament or ulnar collateral ligament. See, medial side ulna is present. That's why medial collateral ligament is also called as ulnar collateral ligament. And lateral side radius is there, so it is also called as lateral collateral ligament is also called as radial collateral ligament. Okay, there's an extra point. So these are all regarding that of the third point called as ligaments. So in the ligaments, first we had seen what is the attachments of the fibrous capsule and what they are enclosing in the upper part of the elbow joint and the lower part of elbow joint. Next is the thickenings on the medial side and the lateral side to provide only the movements as flexion and extension. That is called as medial collateral ligament and lateral collateral ligament. So these are the three ligaments which are associated with that of elbow joint. So with these images, what we had learned? Attachments of these fibrous capsule, and with these two images we have studied the medial and lateral collateral ligaments. So till now we had discussed initially what is the type of joint, secondly what are the articular surfaces, thirdly the three types of ligaments. Now the fourth one that we will be entering is relations. So the fourth, relations of elbow joint. So in these relations, first you have to do the cross section of the elbow joint so that this is the lateral end showing the radius and this is the medial one which is showing the ulna, right, at the level of elbow joint. Now just in front, so let's imagine this is the anterior end and this is the posterior end. On the anterior side crossing the radius and ulna, there is one muscle is there that is called as brachialis muscle. So let's imagine this is a brachialis muscle which is the anterior relation, brachialis. Next, anteromedial to that of brachioradialis, the cubital fossa contents will be there. You know the cubital fossa just in front of the elbow joint. So the cubital fossa contents is the medialmost median nerve. So this is the median nerve. Lateral to that of the medial nerve, there is an artery called as the brachial artery. This is the brachial artery. And further laterally, there is a tendon of biceps. Tendon of biceps brachii. Biceps tendon. So these are all the anterior relations for that of elbow joint. And what is the only muscle that is present on the posterior side is the major triceps muscle. So let's imagine this is the triceps muscle, and posterolaterally there is one more small muscle is present that is called as anconeus. So triceps is the posterior muscle and also anconeus in the posterolateral position. Next, on the medial side, this is the medial epicondyle. On the lateral side, this is the lateral epicondyle. From the medial epicondyle, there is a common flexor origin from which the muscles will be going as a flexor to the front side. On lateral epicondyle, there is a common extensor origin where the muscles will be going on the posterior side, that is called as extensors. So medially, common flexor origin, and laterally is common extensor origin. So these are all the relations with that of the elbow joint. Okay, so these are all anterior relations, these are all posterior relations, this is the lateral relation, and this is that of medial relation. Okay, so that is what the relations of elbow joint is. So see, everywhere we had discussed 2 to 3 images, and a crux of 5 images, everything is completed, and only a short things to be added. What is the nerve supply, what is the blood supply? And around the elbow, we had discussed elbow anastomosis in the previous sections. So the same elbow anastomosis will be giving the blood supply to it. So next thing we will be discussing is blood supply. The blood supply will be by the elbow anastomosis. And what about that of nerve supply is, what are the major nerves that is actually crossing that of the elbow joint is, we have musculocutaneous nerve, and the 3 other major nerves like median, ulnar and the radial nerves. So these are all will be giving the nerve supply. The first one is musculocutaneous, that means these are gives the branches. Musculocutaneous nerve, median nerve, ulnar nerve, and also the radial nerve. Okay, this is what regarding the blood supply and the nerve supply. Now coming to that of the clinical correlations of these elbow joint, the first one is nursemaid's elbow. Nursemaid's elbow. In this, see, usually maids will take care of the children where the both parents are working. At that time, they will not take as much as care like that of parents. So they will just sometimes drag the with the upper limbs, drag the baby with that of the by holding the upper limb, so that there is a partial rotation of these radius at the level of superior radio ulnar joint and dislocate from that of the annular ligament. See here, this is the annular ligament, and from this annular ligament, the head of the radius is dislocated. Head of radius dislocated. So this dislocation of the head of radius from the top of annular ligament is called as nursemaid's elbow. The second one is golfer's elbow and tennis elbow. Golfer's elbow and tennis elbow. Golfer's elbow is also called as medial epicondylitis. Medial side epicondylitis. See, for example, this is a golfer's elbow where there is a medial epicondylitis there, that's called as golfer's elbow, and if it is lateral epicondyle, then it is called as tennis elbow. Lateral epicondylitis. Condylitis is a golfer's and the tennis elbow for the medial and lateral epicondylitis respectively. Next, finally, called as the student's elbow. Student's elbow. So in the student's elbow, actually there are 2 bursa related with that of the triceps. One is outside the tricep or superficial to the tricep, that is called as subcutaneous bursa. Another is deep that of tricep, that is called as subtendinous bursa. In that, the subcutaneous bursa, which is superficial, which is between the skin and the triceps tendon, will get enlarged and inflamed. That's called as student elbow. The subcutaneous bursa enlarged and inflamed, then that is called as student's elbow. So this is what regarding the elbow joint. See, first diagram we had discussed about articular surfaces. Second diagram we had discussed about the attachments of these articular capsule. Third diagram medial lateral collateral ligament. Fourth diagram lateral collateral ligament. Fifth diagram what are the relations. And finally these three images are showing that these the clinical conditions of these elbow joints. That's what regarding the elbow joint is very simplified manner. The last point with respect to that of elbow joint is carrying angle. So next one is carrying angle. Sir, what is meant by carrying angle? See, during carrying anything, there is a certain deviation of this forearm from that of arm, and that deviation is called as carrying angle. Sir, why there has to be a deviation? That's the question. See, in the elbow joint, we have discussed in the trochlea, the medial flange is larger when compared to the lateral flange. Then automatically the ulna, if it is both are equal in size, the ulna will be straight. If medial flange is larger, then automatically ulna will be deviated towards the lateral side, and it pushes the radius also towards the lateral side. So that deviation is called as carrying angle. Okay, so why the carrying angle? First, what is the carrying angle? Is the deviation of forearm from the arm vertical axis. That is called as a carrying angle. Now this is a vertical axis of the arm, and this is actually the continuation of it, but this is a long axis of forearm. So the angle in between these two is approximately 10 to 15 degrees. So this deviation of this forearm angle, this is the arm part and this is the forearm part. So this deviation of this forearm from that of arm long axis is called as the carrying angle. And why this exists is because the medial flange is larger when compared to the lateral flange in case of this trochlea. So as medial flange is large, then automatically the ulna is pushed further laterally, and that's the radius and the entire forearm. That's why the carrying angle is there. And this carrying angle is more in case of females when compared to males. Why? Because the carrying angle in females, the pelvis is much wider when compared to males. So because of this reason, the medial flange is also much thicker in case of females. That makes the deviation further, so that they can carry anything. If they are carrying anything with that of the upper limb, then it will be more easier if the angle is more, because wide pelvis, so that they should not disturb the movements of these upper limb with that of the pelvis. That's what called as a carrying angle. So to summarize regarding the elbow joint, first we had discussed what is the type. So it's a hinge joint, so it permits only the flexion and extension. Next, coming to the top, what are the articular surfaces? The articular surfaces are the condyles of the humerus, that is the capitulum on the lateral side and the trochlea on the medial side, whereas in the lower end there is a head of the radius and also the trochlear notch present in the ulna. These are the articular surfaces. And coming to ligaments, the surrounding these parts of the articular surfaces, there is a ligaments are present, and these ligaments are supported by further strengthening of there is a fibrous capsule part, and this fibrous capsule is strengthened by the ligaments like medial collateral ligament and the lateral collateral ligament. Later we had discussed regarding these the movements, that's what are the relations of these elbow joint on the anterior side and the posterior side. And regarding the movement, the flexion is mainly by the brachialis and the extension is mainly by the triceps muscle. Apart from this, what is the blood supply is by the knee anastomosis, and the nerve supply is by all the major nerves like median, radial, and ulnar nerves. And regarding the stability, it's more stable because of its fibrous capsule and also medial and lateral collateral ligaments. That's all regarding the summary of elbow joint. So the next upcoming topic is regarding of the cubital fossa. What is this cubital fossa and where it is actually present? What are its boundaries and what are the content? These are the things that we will be discussing now. First, what is this cubital fossa? It's a triangular depression which is present in front of the elbow joint. So it's a slight triangular depression in front of elbow joint. This is called as the cubital fossa. And within this cubital fossa, what are the boundaries? So let's discuss about the boundaries. Let's say this is a humerus with its capitulum on the lateral side and trochlea on the medial side. And this is the medial epicondyle. So this is the medial side, this is the lateral side. And extending downwards from that of the lower end of the humerus on the lateral side, there is a muscle that is called as brachioradialis, that is from lateral side to downwards. Whereas from the medial side, there is one more muscle will be extending, that is called as the pronator teres. So the lateral boundary is the brachioradialis for this cubital fossa, and medial boundary is pronator teres. As we are saying, is a triangular depression. So what is about these are the sides, the lateral and the medial are the sides. What about the base? The base is actually an imaginary line which is passing through the lateral and the medial epicondyle. So this is the lateral epicondyle, this is the medial epicondyle. So it's an imaginary line. Imaginary line from a lateral to medial epicondyle. From lateral to medial epicondyles. This is what the boundaries is. So laterally is the brachioradialis, medially is the pronator teres, and the base is formed by the imaginary line which is passing from medial epicondyle to lateral epicondyle. So whatever the gap here you are seeing with the which are highlighted with the yellow things, that is actually the cubital fossa. Now for this cubital fossa, what is the roof? So we had said all the sides. Now we will be going to the top, the roof. The roof is actually formed by, same here. There is a vein. One is a cephalic vein, one is a basilic vein, and connecting the cephalic and the basilic vein is a median cubital vein. And just below this median cubital vein, there is a bicipital aponeurosis of biceps tendon. So the roof is formed by median cubital vein. And we also have on the lateral side is the cephalic vein, and on the medial side is the basilic vein. Also we have bicipital aponeurosis. Bicipital aponeurosis. So these are the things that are present in case of the roof. Laterally is a laterally is a cephalic vein, medially is a basilic vein, and connecting that is the median cubital vein. And relating with the medial cubital vein, there is a bicipital aponeurosis. In this, we have to discuss regarding the details of median cubital vein and what is the clinical importance. Medial cubital vein is the vein which is preferred for intravenous injection. The next question is, why not we prefer that of the basilic vein? Why not we prefer about the basilic vein? Why only the median cubital vein? Because median cubital vein is the most fixed part of the veins. Why it is most fixed? Because it has certain perforators which is attaching to that of the deep veins, which pierces the bicipital aponeurosis. Okay, that perforator acts as a fixator, so that even though if you are injecting, it does not move side to side, as the deep perforator is just like a fixator. So that is why the reason median cubital vein is preferred for intravenous injections. Okay, once again, that it has a perforator which pierces the bicipital aponeurosis to attach to the deep veins. Because of its attachment, it gets fixed. So whenever they are giving the intravenous injection, that vein does not move on either side and it will be fixed. So that is an easy way to give injections intravenously. Or we can collect the blood for any diagnostic purposes. That's about the details of median cubital vein, which is a part of the roof in the cubital fossa. And regarding the floor of the cubital fossa, let's imagine this is the radius and this is the ulna in the cross section. And this is the anterior end, this is the posterior end. Extending from the ulna towards the posterior side of the radius, the lateral side, and then the anterior side. So from this ulna towards the posterior side, lateral side, and the anterior side is the extension of supinator muscle, whereas on the anterior side of the ulna there is another muscle is present that is called as brachialis. So for this cubital fossa, the floor is formed both by the supinator on the lateral side and the medial side is by the brachialis. And what about the contents? So everywhere we had discussed regarding the relations. Now what about the contents from medial to lateral? Let's imagine this is the medial, this is the lateral. From the medial to lateral, there are MBBS structures. What is that? M is actually the median nerve. So this is the median nerve. M for median nerve, which is the medial most. Lateral to this median nerve, there is one more artery is present that is called as a brachial artery. So this is the main artery that will be measuring further out of the BP also. So there is a brachial artery lateral to the median nerve. Further laterally, we have a tendon, and the tendon is for the of biceps brachii muscle. So biceps brachii muscle, one of the tendons will be the tendons will be present here that is called as bicipital tendon. Next, on the lateral most, we have one more nerve that is called as the radial nerve, and that to the superficial branch. So the superficial branch of the radial nerve is present. Superficial branch of the radial nerve is the content from other lateral most. So medial to lateral, these are the structures, and the mnemonic is remembered as MBBS. That's what regarding the top the cubital fossa is. So let's summarize the cubital fossa. And this cubital fossa is a triangular shape with the lateral boundary as the brachioradialis, the medial boundary as pronator teres, and the apex is the meeting point of these two muscles. Whereas the base is formed by the imaginary line which joins the medial and the lateral epicondyles. Right? And this roof will be formed by skin, superficial fascia, and the deep fascia, where the superficial fascia consists of important vein called as median cubital vein. Whereas the floor is formed by both the two muscles, one is a supinator, the other is a brachialis muscle. And the contents include from the medial to the lateral is the mnemonic called as MBBS. M is for the median nerve, B is for the brachial artery, then is the bicipital aponeurosis, and lastly R is the radial nerve. MBBS S is the superficial branch of radial nerve. That's what all regarding the cubital fossa is.